regional wall motion abnormality which occurs earlier, much more earlier than the ECG changes. Now, the latest in this update on this stress echocardiography is stress strain echocardiography. Yes. So, in coronary artery disease, you can have both acute as well as chronic coronary syndromes. In acute coronary syndromes, if it is STEMI, straight away they are taken for the intervention, coronary angiography and intervention, revascularization, and other things. But when there is a low risk non-STEMI or ACS or unstable angina, and when ECG and troponin are inconclusive, we can go for echocardiography with speckle tracking, that is stress strain echocardiography. And you can identify new regional wall motion abnormalities, reduced GLS with the typical regional and 3-layer distribution. This is very important. Regional and 3-layer distribution and risk stratification. I will show the cases later. Then they go for this algorithm. In chronic, we go by the typical physical examination, ECG, echo. When it is positive for coronary heart disease, you can do stress test or coronary angiogram then for intervention, or you can go for stress strain echocardiography. So this is the new algorithm, and stress testing methods are treadmill and pharmacological stress testing with dobutamine. I will show one case of treadmill and one case of dobutamine, and this regional distribution is classically seen, and the coronary mapping. This is what we are talking about. Now, this is the area of distribution. You see, this is the area of distribution of the left anterior descending artery territory. This is a circumflex territory. This is the RCA. Tri-layered distribution. You can see tricolor, the blue, dark blue, then the pink, and then the slighter pink, and then red. So this sort of distribution is very important when you do that. And again, we were demonstrating yesterday, Professor Nanda was also emphasizing on this hypokinetic segments which are marked post-systolic shortening, and dyskinetic segments with late and post-systolic shortening, and entirely passive dyskinetic segments. So these things are important, and you can see here this is the end systolic, and then you have the end systolic shortening. So these things can be identified by the graphs, and these typical examples. This is the LAD territory, and the apex is totally gone, and you can see that in all the areas. This is the apical long axis, 4-chamber and 2-chamber, where you can see this is RCA territory. You can see the patient is having subtotal stenosis of RCA, and this is a distribution of RCA territory in this. So 2D tomography is also useful. Now I will show the treadmill, and the classical protocols are modified bruise and bruise. And for maximal diagnostic accuracy, images should be obtained prior and after. And you need not run after the patient, just like your stress echo, because strain imaging you can pick up with ease. That is the idea here. Normal stress echo patterns are uniformly hyperdynamic motion, and LV ejection fraction improves. So you have the added advantage of having the ejection fraction in single shot. And abnormal stress echo, LV dilates and decreased ejection fraction, a new regional wall motion abnormality appears, hypokinetic, akinetic, or dyskinetic. So patients at high risk, they go for LV dilatation, which suggests triple vessel disease and multiple regional wall motion abnormality. It has a sensitivity of 70 to 86% and specificity of 77 to 95%. So this is the quantitative stress. Now, the methodology which I have followed is using the 3D probe, not the 2D probe. It's very, very important, because 2D probe you pick up at different cardiac cycles. It is not the same cardiac cycle, so the results are tampered. So always use, when you are going to do the stress strain echocardiography, do pick up the triplane view with your 3D probe. So now, single beat acquisition, you have the 4 chamber, 2 chamber, and 3 chamber, and the images have to be good. And then a single start, you get the bullseye map here. So let me go to the first case. This is yes. This is the basal. Just before putting the patient on treadmill, you can record the triplane view. See the triplane view. In addition, you can record the full volume, and both are recorded because ejection fraction calculation is very good. Now the baseline bruise you can see here, and this is the he did only 2.5 minutes, and that was only around 4 minutes of exercise, and you see already he had ST depression in V5, V6, and he stopped the exercise. And see this is the peak. This is the peak triplane view as well as the full volume, and this is the comparison you have. This is the basal stress strain echo, and you can see here the GLS is around -8, and you can see here the tri-layered pattern. This has increased with exercise. The area of tri-layered pattern has increased compared to this. The regional distribution has increased. So this indicates patient has positive. And in addition, you can see the ejection fraction. Ejection fraction basally it was 40%, and at the peak it was 44%. That is the case of stress strain echocardiography after treadmill exercise. It's very easy. But only point is that skilled examiner should be there to just record the single beat acquisition, multi-beat, or single beat acquisition from the apex, the triplane, as well as the full volume at the base and at the peak. Very simple procedure. So before doing the treadmill, we can just place the transducer and do this. Second is the case of a 45-year-old gentleman. He had undergone total knee replacement right side 1 year back. He has developed sepsis of right knee and was planned for exploration orthodesis. He is a non-diabetic for 5 years, and total knee replacement. You cannot ask the patient to put on treadmill exercise. So for cardiac evaluation for surgery, the patient was taken up for DSE. This is a standard dobutamine stress protocol. Same thing is followed for stress strain echo also. The dobutamine dose is increased in increments of 5, 10, and 20. And you can see DSE basal. This is the basal, and this is the triplane view. You can see here the triplane view as well as the bullseye pattern. The bullseye. This is the basal, and this is at 5 mics. This is at 5 mics. You don't find any obvious pattern. This is at 30 mics. See that after atropine and 30 mics of dobutamine stress, this patient went in for this regional distribution. You can see the tri-layer, 1, 2, 3, tri-layer. This typical regional pattern has to be there. So these are the two cases which I will show. This is the post-stress. The most important thing is after stress, that is after dobutamine, the patient settled and there was no regional distribution. So this indicates a positive dobutamine stress echo. So these two cases were interesting, and this is a new technology of using strain echocardiography for stress. Thank you for your attention.